Polis's and Smith's fracture, I think whenever we see this X-ray in our OPD, by looking at the patient per se, by looking at his age, profession, physique, socio-economic status, early return to function, more or less, we are very, very sure what are we going to do with that patient. And these are the simplest of the fractures to deal with, and most common mechanism of injury is fall on outstretched hand. Scope of my talk is I'm going to, and I mean, we will just revise what was the Polis's and Smith's fracture, and today's world, how do we deal with it. So most of the fractures, this is the dorsally displaced Polis's fracture, and that's a Smith's fracture. So volarly displaced fracture is a Smith's, and dorsally displaced fracture is a Polis's fracture. And mainly Polis's fracture will be caused due to fall on outstretched hand, and a Smith's fracture will cause with the fall on the back of the hand. So these are the most common mechanism of injury. Beyond that, just to remember that the fall on outstretched hand, that is the picturization of this is like a C, and fall on backward hand is a Smith's fracture. So when we understand and when we treat this fracture by any method like a plaster or a K-wire or a X-fix or a plate, these are the 5 basic criteria. I am sure that if we just apply, then mainly, in our post-op follow-ups, it will help us to understand how this patient is going to be functionally better. I'm not talking about movement-wise, because these fractures all unite and they have excellent range of movement, but I'm talking about function. So that's why these criteria, I will just go through how do we understand the radial inclination. This is the way in which we calculate the radial inclination. And then these are the 5 important parameters to understand the radial length and radial inclination. Usually it is 11 to 13 millimeter. Then we consider a ulnar variance to understand the DRUJ instability, and then a dorsal tilt. So these are the dorsal and ulnar points on the distal radius and a line perpendicular to that. Theater of ankle is not just to complete that Lafontaine criteria, but it is not applicable in my extraarticular fractures. So this is one Polis's fracture, dorsally displaced, and I have tried to measure the radial inclination, radial height, and radial length, and the dorsal displacement. So if I would like to treat this fracture, say by close reduction, so this is how I will meet my criteria. The method of close reduction has not changed since last 30-40 years. We always give a simple, disengage the fracture or just create the deformity, reduce the fracture in flexion and ulnar deviation, and give a plaster. So I would like to mention here for the beginners about how do we consider a proper cast for a distal radius fracture. Your distal palmar crease has to be visualized. I mean, you have to see it so that the MCP joint movement is absolutely free. Your thumb has to be free from the cast so that the movement becomes free. Patient should be able to make a good fist, and there should be full extension possible at the MCP joint. So these are the proper technique of giving a cast, and rest doesn't change. So make sure that patient has a full shoulder, elbow, and hand function. So if we maintain this, then the complications like CRPS or a reflex sympathetic dystrophy does not happen. Then our good old method of fixing the K-wire. The purpose of K-wire, first we have to achieve a reduction. We have to achieve a radial height, radial length, and a dorsal tilt, and then you fix it. We should not use our K-wire to reduce the fracture. We first reduce the fracture and then fix the K-wire. So under rehab, and that's the post-op, the radiological result at 6 weeks post fixation. So this is how, if you understand these 5 criteria, over a period of usually these patients keep follow up with us for at least 6 to 7 months. After that, they don't come. But then the last follow up, we must have a proper angulation. So these fractures, especially bending fractures, can be treated with K-wires. If you go little more difficult, that sometimes we see a grossly comminuted fracture in the distal radius, where nowadays with good quality of implants, it is possible to plate this fracture, but then good old method of, external fixator, stabilize the fracture with temporary with K-wires and then stabilize it with the external fixator. In this patient, if you see the ulnar styloid, the ulnar head is grossly comminuted and it is dorsally displaced. So this patient may have would have had a ulnar sided pain, so they had fixed it with the tension band wiring. Usually we take apart from PA and lateral view, we take a pronated oblique and supinated oblique view to understand the fracture geometry better. And that's the external fixator was removed at 9 weeks and the TBW, and that's the function. So apart from K-wire and X weeks, then these are the grossly impacted distal end radius extra-articular fracture, where once you reduce the fracture under CM after anesthesia and after complete dripping, look at the position of my thumb. So you have to milk the fracture, reduce the fracture, attain a good reduction, then probably open it, and then go for plating. Again, the criteria of all radiological parameters of Lafontaine we have to match here. So we have to be very, very careful. Sometimes these fractures, there are discussions about whether the wire should be kept out or wire should be left inside. It's all depend on surgeon's choice, but the patient has to have a regular follow-up. So this was the fracture treated by me with K-wires, and on third post-op week, he developed 2 pin track site infection, and we had to remove 1 wire, and we had to remove all the wire. So in spite of, this is not the message, but you have to be extremely vigilant that even a simple technique, if you don't pay attention properly and identify the problem well in time, though the patient will have a good movement, but may not have a function. Though we do also have complications of, treating extra-articular fractures with plating, especially sometimes in a compromised setup of no CM or something like that. But then you have to be extremely careful that these fractures, if we would have treated in just a slab, they would have got better function. But rather than this, creating that, plate, putting a screws intra-articular, we will have more discussion in cases. So this patient was we had to revise the plating. So the conclusion is, choose your own methodology and you have to be extremely vigilant in treating the fracture. The 3 important parameters for extra-articular fracture, apart from all, is radial inclination, radial height, and a dorsal tilt. These are the main radiological parameters we need to observe. Of course, this photo I have put because one has to be extremely careful, in fixing such type of fractures. So return to function is definitely expected, and it is almost always certain. But identifying, the earliest and most predictable strategy is the key. The patient has to decide. We have to give options. If the patient is okay to have a cast for 6 weeks and then to undergo rehab, then their choice. But this elderly lady, wanted to be independent in her work. So, this is 10 post-op day. When I removed the slab, I was explaining her how to wear a cock-up splint. Look at the pronosupination maneuver she is doing to wear a splint. So that kind of independence, they achieve if you fix this fracture by discussing with the patient properly. And does the age matter in planning the surgery? There are many articles. We are not going to discuss any literature here, but the article also says that a properly done plate fixation will definitely give early return of function. And if you compare all this technique, so this of course paper was for all fractures, but for extra-articular fracture, even they say that plating will give early return of function. Thank you so much. Yeah.